Okay, 9:35. We are going to get rocking and rolling here. I am like to welcome you all here and get started. All right, so menopause is mandatory, suffering is not. And the first time I heard that, I thought, yeah, spot on here. So today, what I'm hoping to do is give you some insights and tools to be able to navigate the perimenopausal and menopausal years. And the menopausal years is about 1/3 of your life, so it's a fairly large lifespan here. And you are probably going to be hearing some things that I'm going to be talking about that go against what you have heard in mainstream medicine, perhaps on social media, perhaps from your doctors, your girlfriends, and even from integrative and functional medicine doctors. And there's a reason for that. Because of that, I am asking that you listen here with an open mind, and probably a lot of questions will come up. Some concerns may come up, which hopefully I will be able to address during the presentation. There is going to be a half an hour Q&A session where I'm happy to answer as many questions as I can, as effectively as I can. So the purpose, again, of the webinar is to shine some light and to pull back the curtain on all of the controversy that surrounds hormone replacement therapy. And this is a part 2 of, so far, a 2-part series. And part 1 is located on my YouTube channel. And I'm hoping that if you haven't seen that, you'll go ahead and look at that at another time, obviously. And if you have seen that, is some crossover in some of the information, and I don't think review hurts anybody. And I felt like it was really important to get some of the basics down to have a good understanding about what I'm talking about here. So when I mention HRT or hormone replacement therapy, a lot of women are, just like deer in headlights, because there's a fear that it'll cause cancer. And I think that's the number one concern that women do have when it comes to hormone replacement therapy. The interesting thing is that the number one cause of death in postmenopausal women is not cancer. It is heart disease. So that's the number one problem that we have. And then we've got osteoporosis and then Alzheimer's as well. So I'm going to hop into our presentation here. And I know a lot of the people that have signed up here, but there are some of you who I don't know. So I wanted to introduce myself so you get to see me in 2 different screens here. So what gives me the right or the gravitas to be talking and be in this arena and talking about it? So first of all, I am a functional medicine practitioner and nutritionist. I've been private practice for about 18 years. My focus has been on digestion and then thyroid health and weight loss and diabetes. My main clientele are women 50 and older. I do also treat men, and I love my men clientele. They are easier than women. They're not as complicated as we are. And then I also have my younger women as well. So, but my base is about 50 and over women. And I got into functional medicine about 18 years ago, well, actually longer than that. When I went through my own health crisis, I was going through a divorce. So this was about 23 years ago. I was going through a very, very stressful time, a divorce. My digestive system just totally rebelled. My adrenals were not in good shape. And I actually threw myself into menopause at a very young age, at the age of 43. So I wasn't getting help from Western medicine, and even some of the integrative doctors I wasn't really getting help from. And I stumbled upon Dr. Mark Hyman, who I'll mention again at the end of the webinar. And I stumbled upon the Institute of Functional Medicine. And I took a week-long course with them, and I went, oh my God, I just found my community here. And I took those principles and was able to heal myself, and then have been able to help many, many of my clients. And for those of you who don't know what functional medicine is, It's basically, it's a little bit different than integrative in that, even though it is integrative, it is that we look to find the root cause of why something is not working correctly and out of balance. So that's kind of my background there. And I moved into the space of hormones about 2 years ago. And it was precipitated by or caused by two different things. One was I was watching my clients who had been with me for a while, who I knew how they ate. I knew their lifestyle, I knew their stress level, and I knew that they had a pretty good handle on all of that. Yet they were still losing some ground in some areas of their health. So I kind of stopped and I had to really say, there's something else that I am missing that I am not addressing. So that was one. Number two is my contemporaries. Okay, I'm 66. My contemporaries, I'm watching them lose quality of life, losing the ability to move the way they want to move, losing the ability and the desire to do the things that they had worked so hard all their lives to get to. They wanted to have this retirement where they're traveling, they're doing this, they're doing that, they're doing the things they love to do, but they don't have the energy, they don't have the health in order to do that. So those two things made me stop and think, okay, you know what? I need to really look into it. And I've been on hormone replacement therapy for about 15 plus years myself. And, there's a lot of doctors, and thank goodness, and a lot of women in general, who are talking about hormone replacement therapy. And I'm glad they are, but they're in their 50s and there's nothing wrong with that. But I think a little more mature take on this as we get a little bit older and we can kind of see what happens to the body. There's a big difference from the time you're in your 50s and time you're in your 60s. Let me tell you, there is, even with hormone replacement therapy. So that's where I come from here. So let's move on to what we're going to be talking about today. And it's a lot. And I will keep it to an hour and a half, I hope. Okay, I'll look at my clock here. Okay, so what we'll cover today, one, the basics of perimenopause and menopause, the benefits of estrogen and progesterone, the different types of estrogen and progesterone, the history of hormone replacement therapy, the study that rocked the world as far as HRT is concerned, different types of forms of hormone replacement, when to stop and start hormones, the elephant in the room, the possible elephant in the room, cancer and hormones, the benefits and risks of non-hormonal treatment of post-menopausal conditions, and the fact that HRT is not the end-all be-all is actually just the icing in the cake. And yes, I am going to be mentioning a program that I'm putting together. It's not quite available yet. It's called Women of a Certain Age. And how to opt into it and what that's going to be about. So that's just going to be a short blurb on that. So perimenopause. It is been often coined as our second puberty because it is a time that's similar to our first puberty, where our hormones can be all over the place, all right? There can be an imbalance. There can be a spike in estrogen and then a lowering of progesterone. So in the first 1 or 2 years of puberty, for many young women, there can be just a little bit of going around here before the body stabilizes. Well, same thing happens in perimenopause. Usually we first see what happens is that progesterone drops, and that's why we can feel more anxious, have a little bit more time or difficulty sleeping. We'll start having other body things, but it's usually the progesterone that drops first, and then the estrogen will drop secondarily. And in between all that, it can be up and down like a roller coaster. By the way, before I go any farther here, I do want to say that everything that you're hearing here today, I forgot to tell you this, is for information only. And it's always recommended that you do check in with your healthcare provider before you change your diet, your lifestyle, what you're doing as far as exercise and supplementation and hormones, of course. So again, this is for informational purposes only. Gotta have that disclaimer, right? All right, so again, we can be on this roller coaster. And some women, like this one on the right here, can be going through it going, oh, I don't know what you guys are talking about. I feel just fine. I might have a little hot flash here and there, but that's it. And then we have this poor woman on the left-hand side who's going, hanging on for dear life because she's suffering from insomnia. She has no libido. She's got night sweats. She's got other sweats. She's got hot flashes. She's got a little bit of weight gain. She's anxious. Her thyroid perhaps is shifting around. And she can be a little snappy too, right? That little snappiness, again, is our hormones doing this big fluctuation throughout the entire cycle. So again, we have the drop in progesterone, and then it can be an imbalance. So we can have a spike in that estrogen, where it's not really a spike, but it's just an imbalance here. And I mentioned thyroid shifts. So, and that can be associated with weight gain. And what else is associated with weight gain is when we have that drop in the estrogen. And I'll tell you why in a minute. So thyroid shift. If you have hypothyroid going into perimenopause, and if it is, and most women do have it in the form of Hashimoto's, which is an autoimmune disease. So autoimmune diseases can tend to rear their heads up again, even if you've had them under management prior to perimenopause. And the reason being is that estrogen calms and progesterone also calms, and it reduces inflammation. And so when those start to dissipate and start to go away as our ovaries start to shut down, we can have a spike in all of that. And some women have no idea if they have Hashimoto's with their hypothyroidism, and they have no idea what their autoimmune markers even look like, which you should know. Okay, so I'm a big proponent of really good lab work, which I didn't mention before, but that's something that I do, and helping my clients become their own healthcare advocates. So, perimenopause is a 10 to 12 year precursor to menopause. The average age of menopause is around 50, 51. Some women can start the perimenopause shifting into that as early as 10 years prior to that. So every woman is a little bit different. I always do like to look at the adrenal glands during this time as well. Often for women around this age, it's kind of their busiest time of their lives. Often they're raising children, they have maybe some aging parents, they're working. I mean, the load that's put on women these days is very different than it was a generation or two ago. And I think we're seeing the downfall and the effects from that. But supporting the adrenals is a super important part of all this as well. So taking the whole thing in. Okay, so we go through perimenopause, we kind of get through that, and things are kind of leveling out a little bit, and we've arrived, right? We've arrived to menopause, and what's that arrival date? It is an arbitrary, believe it or not, line in the sand where if you haven't had a period for a year, you are supposedly cross that line, you're now in menopause. And the thing is that some women, if they'll have a period, they haven't had a period for 6 months, and then they have a period, they think they have to start all over again with the counting. But if you have 1 or 2 bleeds during that time, you're still in menopause, okay? It's just a bleed. It's probably what they call an anovulatory bleed, which means you haven't ovulated, okay? So you've arrived, and you're not feeling so great, right? You're feeling a little frazzled, a little frumpy, a little fat. And it's like, wow, this is not a really nice party trick here. And I even had someone say they feel like they're decaying from the inside out. I thought, oh my God, that's an awful feeling. So we don't have to be like that, right? We can either be that cartoon that you just saw, or we can become this graceful, wonderful woman, which we are. We have lived life. When we hit our 50s and older, and I would say 60s, okay, is even better. We have lived, and we have a lot to offer. And if we're not feeling good, we don't have the energy, we're in pain, we have other things that are going on, we have brain fog, we can't think, we're just not feeling very energetic at all, and it becomes this downward spiral. That's what happens. It's really hard to be able to go out in the world and give the world what we have to give. because we don't have anything to give. So I really would like to change that. So your body has usually calmed down from that roller coaster of the hormones going up and down during perimenopause, and it's kind of in a state of calm, and that's okay. And it will feel like it's changed forever, and it has, and that's okay. But we can support it in many, many different ways so that we can still live with a lot of vitality. At this time, we basically do not have any estrogen. We have some, very little estrogen floating around in our bodies. We have pretty much no progesterone floating around in our body because the progesterone is basically made from when we ovulate. So if we're not ovulating, we're not making the progesterone. We do have some testosterone. We do. It has dropped a little bit, but we probably have more testosterone than anything else. And what else do I want to say about this? Well, I think I'll talk about this when we go into all the functions of estrogen, which we are going to go into right now. So let's look at the benefits of estrogen. And I'm talking about basically the estrogen that is in our bodies during our fertile years, which is the estradiol, which I'll be talking about, the 3 different types of estrogens in just a minute. So estrogen, when we're young, it's what keeps us young, okay? It's our life-giving hormone. It's not just to make babies. It's not just to procreate. It's beneficial on so many different levels. And these are all the levels here. So it increases energy and focus. It improves sleep. It prevents osteoporosis, and that's even FDA approved to prevent osteoporosis. Prevents heart attacks and strokes. It's neuroprotective, which means that it helps and protects the brain. And there was just a new study that came out that supported that. It increases sexual desire. And for some women, intimacy is super important much later in life. And definitely, I would say for most women, if they're in their 50s, when they're switching over to menopause, it's still a very important part of their relationship. It keeps our urinary tract healthy. It reduces incontinence. It regulates weight. It regulates appetite. It regulates mood. So often, when we hit menopause, our appetite can kind of go wonky. It increases insulin sensitivity. So that plays a huge role in diabetes. It also plays a huge role in that abdominal weight that we see. Okay. So when we start losing our estrogen in perimenopause, our bodies are super intelligent and smart, which is one of the things that just amazes me all the time. And what we'll see is that the body will, for 2 reasons, will tend to start putting fat on in the abdominal area for 2 reasons. One is that's where it starts making its own estrogen, is from fat tissue. So it wants to lay down some fat tissue in order to make estrogen. It's not the right kind of estrogen. It's not the estrogen that we want necessarily, but that's our body's attempt to do that. We also lay down fat there because we usually do become less sensitive, insulin sensitive, and our blood sugar regulation starts to go a little bit cattywampus as well. So those are 2 reasons that we'll start laying down the fat. We will gain weight too for that reason, just overall, and even in the breast area. Again, our bodies can make estrone from our fat cells through an aromatase enzyme. And for any of you, if you're on here and you've had cancer, you understand aromatase because you are often given an aromatase inhibitor when you do have breast cancer. So it's shutting down that our body's ability to make estrogen from our fat cells. Okay, it keeps inflammation in check. And I mentioned that before, and you will hear inflammation sprinkled throughout this entire presentation, and it is huge. It is the cause of all chronic disease. It affects our digestive system. So our guts can become a little more sensitive, a little more leaky when we lose our hormones. And then it can prevent gallbladder issues. So gallbladders come out the most in postmenopausal women. The second most would be after a woman has had maybe 2 or 3 babies, and babies require a lot of choline, and choline is a backbone of making bile, and bile has to do with gallbladder. And this might be surprising to you, but estrogen also reduces breast and ovarian cancer. So let that sink in for a minute and just hang with me, okay? We're going to move on to the different types of estrogen. Okay. So estrogens, there's a family of estrogens, and we're going to talk about 3 of them here. And they all work a little bit differently in our bodies, and we really do need to understand the differences, just like a carbohydrate's not a carbohydrate, right? In the carbohydrate family, we can have sugars. That's a carbohydrate. We can have carbohydrates that are found in vegetables and fruits, which are very different even from each other. We can find carbohydrates in whole grains, and then we can find carbohydrates in very processed foods. And they all work very differently on our bodies in different areas, okay? Same thing with the estrogens. So let me go through them and give you a little bit of understanding, because it's super important to understand the differences when we talk about different studies, when people are speaking about estrogen or progesterone. We have to know what type, and often they do not delineate or make the distinction between the different types of estrogens or progesterone. So you have to, listen very, very carefully. Okay, and also what is going to be given to you possibly by a doctor. You need to know what's out there and what is most beneficial for you. So first one I'm going to talk about is estradiol, and it's called E2, okay? And estradiol is the most abundant form of estrogen during our fertile years. It is produced in our ovaries, and we love it. And it gives us energy. And again, it helps with our libido, and it can help as an appetite suppressant. And hopefully you have experienced this at some time in your life. So when we are right about the time we're ovulating, that's when our estradiol is the highest. Often that's when we are just on fire, we're getting things done. It's often when we want to have sex, right? And for a reason. We were built that way, we were designed that way. And often that's when maybe our appetite is a little bit suppressed or subdued. So hopefully you have felt that at some time in your life during your fertile years. It's also extremely anti-inflammatory. And so it keeps inflammation down in our bodies during that time. And when we lose it, that's when the inflammation and aging. So inflammation is also very aging. That's when the aging accelerates, is when we are postmenopausal. The second one I want to talk about is E1, or estrone. Now, estrone can be made from estradiol, and our body does make it during our fertile years. And we do need some, just not a lot. We do need some inflammation, because if we didn't have inflammation or the ability to respond in an inflammatory way in our bodies, we would bleed out. So like we get a cut, if our bodies don't clot, send little clotting agents, okay, which is inflammatory, to that area, we're going to bleed and bleed and bleed. So we do want that. We want some of that. We can't do without it, but there's a balance with it. And again, it's produced by our fat cells. So the more overweight that we are, probably the more estrone that we will produce. And again, it is inflammatory. And inflammation drives all disease. And you will hear me say that again and again. Okay, and then we have estriol, and that's E3. And that is the least abundant estrogen usually circulating in our bodies unless we are pregnant. And that's the most abundant when we are pregnant, most abundant estrogen while we're pregnant. And it is the most anti-inflammatory. And if you think about it, we want to reduce our inflammatory response when we are pregnant, because we do not want the fetus to be attacked. So it's just kind of that balance there. There have been some studies with using estriol in relationship to MS, because that's a very inflammatory neurodegenerative disease. And that can calm things down. And they're looking at estriol, they've been looking at it for many years, actually. Just not a whole lot of studies on it, and not big studies on it. Again, to prevent breast cancer and other things. So these are basically the three that we need to keep in the back of our mind when we're talking about things. So let's move to the benefits of progesterone. So progesterone is really important, and it does prevent the thickening of the uterine lining, and it's very calming and improves sleep. It also plays a role in preventing osteoporosis. It lessens anxiety. It actually has a role in building muscles, which I think we think more of testosterone than anything. And then it is neuroprotective. So we do have receptor sites in our brains. It's very, very neuroprotective. And it can help with dementia and Alzheimer's. And Alzheimer's with women, it is very sad, and it's a hard disease, and we really still don't have anything on the market that is effective as far as pharmacology is concerned. So we're going to talk about the two different types of progesterone. So this is one where when people are talking about studies, they hardly ever make the distinction between the two, and it should be distinguished. Distinguished, that's probably not the right word, but anyway. So they do very, very different things. They're found in different places. So let's look at what progesterone does. So progesterone improves cardiovascular health. It may reduce the risk of breast cancer and is good for mood and sleep and calming, anxiety, all of that. Whereas progestins, which are man-made, okay, they're not bioidentical. Now, bioidentical hormones can be man-made too, okay? Bioidentical means that it has the same chemical structure as our own hormones do. And they can be prescription, they can be in pill, and I'll be talking about that. But a progesterone has a different biochemical makeup. And we find that in our birth control pills. We'll find that in our IUDs, the Mirena IUD, and a couple others. And these can cause high blood pressure. They can increase the risk of heart disease and the risk of breast cancer, and can cause anxiety and depression. Anyone's taken pills and they didn't do well with it, it could be the makeup the pill. But these are very big distinctions here. And we're going to be talking about a study. It's called the Women's Health Initiative, which is over here, the WHI study. So progestins were used in that study. And that study is the one that set the whole conversation in the last 22 years, okay? And again, I told you it's found in the birth control pills, and it's also found in a patch that's available to women that I'm seeing some doctors prescribe for even some of my clients. I'm like, no. So it's in a patch, in a transdermal patch. So progesterone, which is a bioidentical, that can be gotten in oral form or cream, or even you can use it vaginally. Am I going to be talking? I might have to go back to the progesterones again of how to take them. Okay, so real briefly, I do like to do a quick history of hormone replacement because I think it's interesting. So I started in 1940, but even before then, in China, Chinese women were taking hormone replacement therapy, ancient, and what they were doing was that they were using the dried urine from fertile women, okay? Well, we kind of moved to using the dried urine of pregnant horses. So equine estrogen, which probably isn't the same as ours. And it is the waste product or the metabolite, right, of the hormone that they have because they're peeing it out. It's basically the metabolite, it's basically the waste product. But it was effective, okay? So in 1940, Premarin, which is estrogen only, was FDA approved to treat menopausal symptoms like hot flashes and mood swings. And it's like, whoa, okay. And then in 1966, the book Feminine Forever had women flocking to their doctors for HRT. They were handing it out. And then the 1970s, so about 4 years later, they went, uh-oh. Estrogen does grow the uterine lining, and if we need to have progesterone to counterbalance that. So if you have a uterus, you must be taking progesterone. Even if you don't have a uterus, I still recommend taking progesterone because all the benefits that you just saw that estrogen, progesterone does. So when they added progesterone to estrogen in a pill form, it was Prem Pro, and it was progesterone that they added it to it. They had not discovered the absorbable micronized progesterone that is now available today in an oral form. So that was the only way that they could come up with it. And then in 1992, it was the #1 prescription in US, which is really not surprising, but it's just such a juxtaposition when we look at how many women use hormone replacement therapy now. And I think it's like only 7% of postmenopausal women. That's it. That's it. So then we moved to 1993 to 2003 or 2002. And that's when the Women's Health Initiative study was done. And that, if you want to know more about that, which I hope you will look into my YouTube and look at the part 1 of this series. So the Women's Health Initiative was a huge clinical trial. So it took a lot of money. All right. We haven't seen one since then when it comes to women's health. And it was put together basically to look at and study the effect of estrogen on heart disease in women and in postmenopausal women. That's why it was constructed. So what happened is in 2000, and there was 3 arms to the study, okay? I'm not going to get into all of that. But in 2002, one arm of the study, it was the estrogen, and remember, this is the equine, right? Estrogen, it's not really bioidentical. And it's the progesterone. It's that arm of the study. It was the 2 of those combined, progestin. That was stopped prematurely. And it was stopped because there was an increased risk of breast cancer. Now, this study has been re-examined over and over and over to nauseam, again and again and again. And even if there was an increase, it was so insignificant that it should never have been stated that way. So it's 1 in 1,000 women increase. That's it. Okay. And you have to remember, again, that was using progestin, not a progesterone. So what happened is the report came out, got to the media put it out there, and women dropped their HRT like hot potatoes, which you can't blame them, and doctors did too. Okay. So now that we have established that hormone replacement therapy causes cancer and is detrimental to women's health, well, we're no longer going to teach about it in medical school, right? So there's like 2 decades of doctors who've gone through, or more, who have gone through medical school that have never been trained in the area of hormones and really of postmenopausal health. And that's why there's such a dearth of doctors who are comfortable at even offering HRT to their clients. I have to encourage each one of my clients to go to their doctors to request for hormone replacement. They have not been offered it, even though they may have many, many different symptoms. Okay. So we have to go and ask for it. They are not trained. To be trained, they have to go outside of Western medicine and they have to be interested in it and they have to pay for the training on their own. All right. So that's the problem. That is what the basis is that's surrounding all of a lot of the narrative around HRT. Okay. 2017, so we're talking about 15 years later, NAMS, which is the North American Menopause Society, which is highly respected, of course, in North America and actually all over the world. They recommend using the smallest dose possible for the shortest period of time, mainly to relieve what we call the vasosymptoms of menopause. So mainly to relieve the hot flashes and the night sweats and things like that. That's what they're looking for. There was no real study or basis to come up with this, but I think they were trying to be very cautious, but you can't blame them. And this is kind of what again, the narrative was from about 2015, 2017 on. Then 2 years ago, NAMS came out with another statement, and which was very, very different from the first one. And they're recommending higher doses if needed and indefinitely. And the report, their statement also clearly states that HRT does not cause breast cancer, and there is no increase of morbidity from with breast cancer from hormone replacement therapy. So that was huge. What they came up with again is that the number one risk factors for breast cancer is alcohol, being overweight, and smoking. By the way, this report, you can Google it and you can download it yourself. And I found it fairly easy to read. All right. Just recently, there's another study that came out, and this kind of dovetails into when do we stop and start hormones. But there was a study came out, and it's a 10 million women study, and it's by it's an observational study. We're gathering information from the Medicare system of women who were on hormone replacement therapy. And basically what it came up with is that estrogen only HRT had a reduced risk of all-cause mortality of up to 30% postmenopausal women who took HRT, and about a 20% reduction of breast cancer incidence and mortality from estrogen only. It isn't as clear, the estrogen progesterone combination, but it also reduced mortality. So that's kind of the progression. We're kind of coming back again. And part of that is so many women are hitting their perimenopausal and menopausal years, reporters and this and that. We're just getting so much information because there's such a big number that are entering these years. Okay, so let's talk about the types and methods of HRT that's available today. So we have oral, transdermal, pellets, and vaginal. The oral is not necessarily my favorite for estrogen. You can take progesterone orally, and that's fine. In the micronized form, which we talked about, which is bioidentical to our progesterone. And for some women, it works better. I think doctors prefer that. It works better as far as calming, as far as sleeping. Some women have a difficult time taking oral estrogen. I'm one of them. My digestive system doesn't like it. It's very finicky. So I do the transdermal, but that's an option. I'm fine with that. But as far as oral estrogen, which is available in either a pill form or troche form, which a troche is like a lozenge that you suck on, and some of it does get in sublingually through the salivary glands, but majority of it is swallowed, and it has to go through a hepatic or liver pass in order to be processed. And so when it goes through the liver, it turns into that more inflammatory type of estrogen, not all the way with the troche, which is the estrone. Now, having said that, there may be some women here on the webinar who love their oral estrogen. They've tried transdermal patch, they've tried creams, they've tried other things, and for whatever reason, it just wasn't a match for them. And that's fine. And if you've gone that route, you can't find something that works for you, I would say then maybe try the oral troche. The oral estrogen pill usually is the old pill. It usually is either the Prem Pro or the Premarin, which is what they used, over 20 years ago. And it's like, why would doctors use that? There are some older doctors who are still using that, unfortunately. It's like, don't find another doctor, or at least talk to them. And if they're not willing to try a different method, I would recommend finding another doctor. Okay. Transdermal is probably my favorite, and I would say favorite of most of the doctors who are in this field, who I respect highly. And it can be either a transdermal patch or a cream. And by the way, insurance will cover the oral progesterone. It will cover the transdermal patch. The creams, either progesterone or estrogen, will be compounded at a compounding pharmacy, and that will not be covered by insurance. So there's different ways of going. The thing is with the creams is that you have more wiggle room, right? You can kind of vary the dosage and play with it a little bit more than you can do with a static dose with either a pill or with a transdermal patch. But our skin absorbs these hormones very readily. And here again, every woman is different. And I do want to say this. Some women, they're put on, a certain level of estrogen and then estradiol and then progesterone, and they're dialed in there, right? They're doing great. But I would say majority of women will require a 3 to 6 month journey to figure out what exactly works best for them. And so be patient. Try to find a practitioner who will also be patient with you and work with you and be willing to make some adjustments. I'm kind of going off here, but I just want to make sure I do include this because I think it's really important. And that is, we have to have the right kind of balance between the estrogen and the progesterone to make sure that that uterine lining is not proliferating and becomes thick, because that can cause problems. Possibility is leading to uterine cancer. So I personally do recommend that once you kind of find that sweet spot of what you like, as far as the estrogen and progesterone, what you're taking, that within 6 months, maybe to a year at the outside, you request a transvaginal ultrasound to make sure that the uterine lining is looking good here. Okay, I think that's really important. I know a lot of doctors don't do that. I've run into problems myself, which is why I'm really a proponent of it. At least do it once, and then if you ever change your combination or dosage again, then again I would say be tested. Okay. Then there's pellets, and some women love their pellets. And but I would say, from listening to again the professionals in this arena and even clients that have been mine who have had pellets before, we can have a nightmare with pellets. And the biggest problem with pellets, I would say, is that often they're overdosed and they're too high. You don't know what a woman needs, right? And then once it's in there for 3 to 5 months, and you just have to wait it out. You have to write out the problems if you do experience any. And women like it because it's kind of a hormone high in the beginning, because you're going to get the highest amount of dosage, and then it slowly wanes throughout the 3 to 5 month period. And some women are kind of climbing the walls at the end and before they get their next round of pellets. So that's one of the reasons why I don't like pellets. Another reason why I don't like pellets is it's often offered by anti-aging clinics, and the doctors really are not interested in your overall health. Pellets are a money-making machine. They are. Usually they'll go to a weekend course, and then they get to give you pellets. So for all those reasons, I don't like it. I do know a couple doctors who are very much respected. I don't know them personally. I haven't really heard them talk that much. but are respected in their field and by the doctors I respect. And they do like the pellets, but they tend to do lower dosing. Okay, then we have vaginal hormone replacement, and that's the most conservative, and it can be a cream, it can be a suppository, it can be estradiol, or it can be estriol. Remember, estriol is the weakest. And what's wonderful about the vaginal route of dispensary is that it stays pretty local. So if a woman has had cancer, most oncologists are on board with giving a woman a vaginal suppository or cream in order to help the whole urinary tract system, which is really important for her overall health and just comfort and even possible intimacy. By the way, you can also use your oral progesterone. You can put that in as just put it up there, put the little pill up there, and it hits right at that uterus. So that can be effective for some women who have a hard time taking it orally, and they just have a hard time with progesterone in general. By the way, transdermal can be estriol or estradiol or a combination of the two. I'm not going to go into that right here. It's just too much, but those are options. Okay, so how and where can you get your hormones, right? We want to know that. So there have been a lot of online companies cropping up that will service women who are about 45 to 60, so that perimenopause to that 10 years out from the menopause, time of menopause. And there's two that I know of. I know there's more than that, but there's Alloy, there's MIDI. I don't know exactly how they work because I'm too old, right? They're not going to touch me with a 10-foot pole. I actually tried, and they said, we can't service you. And so you fill out an application, they pair you up with a practitioner, and then that practitioner will prescribe your hormones for you. I think you pay a monthly fee for your hormones. I believe they're compounded. And then I believe you also get to check in with your practitioner. So it's the price that you pay for your monthly hormones, I believe, also includes your consultation with your healthcare provider as well. So there's that. There are websites that train practitioners in hormone replacement, and I know of two. There's more than this, but David Rosensweet, MD.com, he trains, and so he'll have a list of practitioners that he has trained. Remember, hormones are not for the faint of heart. And so even though these doctors are trained, it's going to take them a few years to really understand and get the nuances from different women. I mean, I'm still learning too. Okay. And then NAMS, which I've already mentioned, the North American Menopause Society also has a training program, and they have a list of practitioners. Again, you're going to have a variation of how much they know and what kind of training they've had. Then I like pharmacies. I really, really like in the regular pharmacies to find out what doctors are maybe prescribing the patch and the micronized progesterone. You can go to your regular pharmacy, CVS, Walgreens, because that's where that's dispensed, and find out what doctors the pharmacists like, and maybe, contact them. And then if you want a cream, a compounding, then you would go to a compounding pharmacist and maybe ask them what doctors do they really know what they're doing and they enjoy them. That's how I found my doctor that I currently use now. I asked for a doctor who takes Medicare, right? Who does compounding pharmacies. That's what I wanted. Okay. You can also get over-the-counter progesterone. You do not have to have a prescription. And you can get over-the-counter estriol and even a little estradiol, usually in small amounts. Those would be probably more for maybe the vaginal area. If like some women are still a little bit dry in the vaginal area, I would say they're not taking enough estrogen oral or systemically, but you can do that there. You can also, estriol and estradiol is really good for wrinkles on your face too. So some women buy those products over the counter for those reasons. All right, when to start and stop HRT? Maybe you guys need to take a breath here. I don't know. But yes, that has changed a lot. And I would say that a lot of doctors don't do this, but starting in perimenopause would be probably the best place to start, especially with women who are suffering from a lot of symptoms. So again, your progesterone drops first, right? So you're going to have this imbalance. You're going to be on this roller coaster. So I would say that putting a woman on a little bit of progesterone can be super duper helpful for her. And I would say the symptoms would kind of mitigate when and where and how much. And then as she moves closer to the menopausal years, to menopause, she might need a little bit more, she might need a little bit of estrogen. Now, doctors they're ready, Western medicine, to prescribe a woman birth control, right? If she's bleeding a lot, which can happen during perimenopause, because again, that progesterone drops down and that estrogen's way up there. It's building that uterine lining, and we can have a lot of bleeding in some women. So the thing to do is to start taking some progesterone, but the pill is not the way we want to do it because we know that the pill is progestin. Okay. We don't want to be doing this as the woman is becoming more inflammatory. We do not want to push that whole inflammatory cytokine response. We don't. So if a doctor hands you birth control, I would say, excuse me, can we maybe look at taking permetrium, which is the oral form of progesterone? Okay, start there first. You can talk to the doctors often if you have something specific to suggest. Not all, but a lot of them are open to it. So starting in perimenopause, again, depending on the woman, depending on her symptoms, is the place to start. And then how long? Well, NAMs changed their position on the length of time. There's still a lot of doctors who are very hesitant about keeping a woman on hormones past, I don't know, the 10-year window after she's went into menopause. It's like, did all the things that estrogen is helpful for, that progesterone is helpful for, does that automatically go away after 10 to 12 years? No, it does not. So having a woman come off of it is not really understandable, although, having said that, it goes back to the Women's Health Initiative study, the WHI, where interestingly enough, the majority of the women, or the average age of the women that were enrolled in this study, were 63. So if you think about it, most of those women had been past menopause for at least 10 years. Now, how many of them were on hormone replacement prior to entering the study? I have no idea. I have no idea. But so it goes back to that, saying that there's some risk factors. And here again, we have to remember the hormones that they were using back then are very different from what's available and what we can use today. So I'm going to push back against that. HRT can still help with bone health, heart health, brain health, and everything else. So for a woman to stop her hormone replacement therapy makes absolutely no sense to me at all. Okay. Now, we already talked about when a woman would start hormone replacement therapy, and perimenopause would be great for a lot of women. But what about the woman that was never offered any hormone therapy, which is the majority of the women 65 and older? They were never offered any at all, partially again because the Women's Health Initiative study. So what are they going to do, right? So is it beneficial for them? Is it risky for them? Again, we know that estrogen and progesterone reduces inflammation. So that right there, and the type of hormones that we're using, I would not use oral in a woman older, especially if she hasn't been on hormone replacement therapy. I would not use oral. I would definitely use a patch or a cream, just to be on the safe side. So will she get benefit? Right? Maybe she's already lost some bone. Maybe she's already become a little more insulin sensitive. Maybe she's already experienced some dementia and maybe even a little bit of Alzheimer's. We can't reverse that damage necessarily, but what we can do is mitigate ongoing problems and harm going forward. We know that women still at age 70, 75 still have estrogen receptors all over her body and in her brain too. And so giving her estrogen and or progesterone can help with every single tissue in her body again. Now, maybe those receptor sites have gone a little bit dormant, they've gone a little bit quiet, and maybe we want to start out slowly and build up. I think that has been recommended, and I think that's probably a smart thing to do. So everything that I've heard and just what makes sense to me is that women who are 60, 65 years and older who have not been on hormone replacement therapy before, I think can benefit greatly from transdermal type of estrogen and or progesterone. So you can stay on it forever. All right, let's go to the the elephant in the room here. So I'm talking all about this HRT, but what about cancer, right? Do hormones cause breast cancer? And I'm going to go to my notes a little bit because there's just so much that surrounds this, and I don't want to miss it. Okay. So no, hormones do not cause breast cancer. And before you put your arms up and shake your head, I want you to think about two different things. One is 1 in 8 women will get breast cancer of some form during their lifetime. 1 in 8. Majority of breast cancer occurs in postmenopausal women. Let that sink in. That means it occurs in women who have the least amount of estrogen, and particularly estradiol, circulating in their bodies. It's when their estrogen is the lowest. It's when their inflammation is the highest. It's when the inflammatory form of estrone is the highest. Okay? So it's not HRT, it's not our own estradiol during our early years that causes the cancer. Something else, which we will talk about. So what about the estrogen and or progesterone positive, receptor positive cancers, right? Okay, what about those? Which I would say, I don't know what the percentage is, but a large percentage of cancers are those. Isn't estrogen and progesterone causing those? No. The tumor has been formed for reasons we'll be talking about. And on those tumors, they have receptor sites for estrogen and or progesterone. And yes, that will help grow the tumor. It's part of it. It is part of it. So obviously, when you have a tumor, okay, that's estrogen or progesterone positive, you are not going to want to be taking hormones because it'll be proliferative. It will be. But once the tumor is taken care of, once the cancer is gone and a woman's been treated, there is room to revisit on so many levels the possible use of HRT. There's oncologists out there that do talk about it, and you will see in the resources. There is a 2 to 3 time breast cancer survivor. There are survivors out there that do take HRT. And it's nice to hear their stories. It's nice to know what they're doing. It's nice to hear their journey, whether or not you choose to do what they're doing. Okay, we need to know our options. We need to have knowledge before we can make any decision. And this decision is very personal for every single woman for very different reasons. And I'm learning that more and more. So what causes breast cancer? All cancers are a misfolding or a misreplication of our DNA. That's our blueprint in our cells. All cancers and diseases are caused by inflammation. All diseases, all chronic diseases. Inflammation and genes are turned on and off by our environment, which is our epigenetics, right? So let's talk about, just a minute, our epigenetics, what happens in our environment. So our diet, right, is a big part of this. We want minimally processed, organic. I mean, this is a whole nother webinar if we want to make it that. Alcohol is super inflammatory and on many, many different levels. We want to make sure our digestive system is working properly. We want to make sure our digestive system, we're pooping things out. We got to eliminate our toxins. We got to eliminate the metabolites of our estrogens. And so we have to make sure our bowels are moving, but we also have to make sure that those toxins and those metabolites are not coming unhooked from our bile, which is a whole nother thing. But that all happens in the digestive system. So I do like to look at that in my clients. Our body composition is huge, even if we're not overweight. If we are under-muscled and over-fat, which can happen in a lot of people, especially over 60, we're going to have more inflammation in our bodies, and we're going to have less muscle mass, and we're going to have be more susceptible to osteoporosis and amongst inflammation. Excuse me. We want to minimize our exposure to environmental toxins, and that would be pesticides, would be herbicides, so definitely what goes onto our food, but also all of those things that we're exposed to on a daily basis, like our fragrances, okay? What we put on our skin, our lotions and our potions, laundry detergent, our water, all of those things have a role. And some people are better at detoxifying and eliminating these things than other people are, okay? We want to upregulate our detoxification system, and that means supporting our liver. That means something called methylation, whole nother topic, but not. And when we think of methylation, think about your B vitamins. And then also making sure that we have plenty of magnesium, and that helps with methylation as well. So touching on this really, really briefly, I know a lot of women and doctors too will want to test their women for the BRCA1 and BRCA2 gene. And that is a risk factor for breast cancer. Okay, and again, we can turn on and off these genes. A very small percentage of breast cancers are, do women have the BRCA gene? If I was a woman and I was concerned about this, I would do something that's called a Dutch test. It's a urine test. It's looking at your metabolites. It's looking at what pathway your body sends your estrogen and estrone down. And we want to look if it's a more inflammatory pathway or non-inflammatory. It also looks at our methylation status and things like that. So it tells us what our body's doing, and that gives us the insight of how to best support your system, your body. So again, this all has to do with turning things on and off. And some people genetically are better at it than others. And we kind of want to see inside to see how we can support. That was a lot. This is all a lot. I know that. Okay. Risk benefit analysis. So we always have to look at the risk and benefit, right? So what I've done here is I've listed some of the chronic conditions and diseases that a postmenopausal woman will have, what she can do for it, and what the risks from treating it this way, okay? So we can have an increase in UTIs, and how is that treated? It's treated with antibiotics. So what happens with that? We will have a change in the microbiome in our digestion, and we'll have a yeast overgrowth, and it can be actually very, very incapacitating, and it often reoccurs. Bone loss, okay, bisphosphonates is usually what's used. There's another medication too, and actually what happens is it might keep everything in the bone, but it kind of demineralizes it, and you have to take it forever, and then there's a problem with that, and we'll have weak bones and falls and broken hips and death usually shortly thereafter. And why do people go to nursing homes? It's usually because they've lost mobility, so broken hips, or loss of muscle mass and sarcopenia. They don't have the muscles to hold themselves up, and dementia, things like that. So Alzheimer's and dementia, okay, there's nothing on the market that really helps. The best thing that I believe that we can do is treat with estrogen and progesterone. It's very, very neuroprotective. Okay, we got depression, we got other things too. And then I'm going to go over to the left-hand side, right-hand side, cardiovascular disease and inflammation. usually it's treated with statins. And what we have with that is we have muscle mass declines. We have additional muscle, joint, and ache pains, and then statins also increase the risk of diabetes. So statins is not what we want, and often cholesterol will go up when a woman goes into perimenopause and menopause. And again, cholesterol is a backbone of our hormones, and so as our hormones go down, the cholesterol will often go up. Part of it's inflammation too, but it's one of our body's way of just trying to make more hormones, so it's not uncommon. Diabetes, usually the first line of defense is metformin. That can give us a risk of cardiovascular disease, kidney problems, loss of limbs as the disease progresses, which often it will. And it can contribute to cancers, and you know, the end result is death. And then we have leaky gut. So yes, we have pharmaceuticals for all of these things. We do. Some are more effective than others, but there's always a risk with pharmaceuticals. And there's a risk with hormones too. I just think the risk is just so low in most women that it just is the way to go, instead of compiling and putting on all of these other prescriptions to treat each different disease or condition. And again, all of these are caused by inflammation. All right. You know, one thing I want to point out here is that estrogen really, you know, is part of collagen and affects it. And when we lose the estrogen, our collagen goes down, and it makes our tissues and our ligaments less pliable. So we'll see plantar fasciitis, we'll see problems with the shoulders and things like that. And again, it affects a woman's mobility and her comfort and her quality of life. All right, we're almost there. So HRT is not the end all be all. And I know that's all I've talked about for the last hour and a half or so. And it may feel like a magic wand for some women. Some women will go on it and just feel so much better. And while it does help our bodies stay young, it is not a substitute for any of the very important roles of all that I've listed below are part of, right? So we've already kind of talked about this. Nutrition is super important. Our gut health is super important. I left something out. Life, really important. And I'll get to it. Lifestyle that encompasses sleep, body, movement. Okay, what I left out on what are drivers of inflammation was stress. That should have been in red, should have been covered the whole page. That's probably the biggest driver of inflammation. And I think a lot of women will all of a sudden cancer somewhere in the body, let's say breast cancer, will come out of nowhere, seemingly nowhere, after a very either physiological stressful event or emotional loss or something like that. So stress is huge. So managing that, getting the help you need is really important. Okay. Environment, where we talked about supplementation. I do want to mention the supplementation, if I was to be worried about things, resveratrol, B vitamins, magnesium, and something called DIM, that can help change the pathway of some things. And then I also mentioned that adrenal and thyroid health is really, really important. And I do like to test a very thorough thyroid panel, especially during perimenopause and menopause, because usually it goes a little cattywampus. So these are just as important, if not more important, than the HRT. We can't do one without the other. HRT is kind of the icing on the cake. That's what it is. So some of the things to remember: one, understand the studies and the analysis of the studies if you're hearing them, if you're looking at them yourself. Most importantly, know what type of hormones were used and are being referred to in a talk, a study, a report, whatever it is. Two, understand the different types of hormones and progesterones and the effect that they have on your body. It's a lot of information. You probably just want to, I mean, so many of us, me included, not in this arena, but other arenas, I just want to go, just tell me what to do, right? Okay. So again, know that HRT is not the end all be all. We need to have support. It's essential to monitor and to retest to make sure that everything is in balance. It's important to find, number 4, a practitioner who will listen and support you, and realize that no one size fits all, ever, ever, ever. And it might be a little bit of a journey for you. So I recommend keep learning and become your own advocate, and also find someone to include on your team to be your advocate as well. So my vision in all this is I love to teach, if you haven't already figured that one out. And my vision is to help as many as I can, many women as I can, lead amazing lives that are healthy and productive all the way to the end of their lifespan. And I think this can be done most effectively by creating a strong community and having a health advocate on your side. And I am hoping to be able to give that to you, or at least point you in the direction, if I'm not your forte, point you in the direction of finding someone who can help you and the resources. So how to work with me. You work one-on-one with me right now. And the best way to do that is to go to my website, alivingbalance.net. And there's an annoying pop-up that comes up on my website, and it'll encourage you to make a 20-minute introductory call with me. And that would probably be the best way to start. If you've already been working with me and you would like to explore this area a little bit more with me, then reach out with the email, or if you're on your portal, you have a client portal, reach out there and I can tell you the best way to go from there. I am working on a program, and it's been a long time coming, and it's been much slower than I would like, but hopefully it'll be done no later than the end of this year, 2024. It's called Women of a Certain Age, or WACA program, and that will be a community. It will be a group. It'll be a 6 to 8 week program where I take women through each part of their lives, okay, for diet and physical movement. So each part of the things that make up our epigenetics, we're looking at blood work, we're supporting you through making dietary changes, we're supporting you through making physical changes. So everything that possibly goes into your well-being, we will be working together as a group, which I'm really excited about because we will be supporting each other. So you're already on my email list if you're on this webinar. And so you'll be getting updates on that. I don't really see it moving much before the end of the year. But if you want to start working with me one-on-one, this would be the time. Okay, some great resources here, and I hope you will jot some of these down. Books, Sarah Godfrey, she's really smart. She's got good books out there. I don't know if this is her latest book. I've kind of moved away from, you know how you kind of move away from somebody, maybe come back to them. She's good, and I think she's got a more recent book out there. Avram Blooming, he is an oncologist, so he's MD. I'm sorry, I didn't put anything by your name. And he wrote the book Estrogen Matters. So he's an oncologist, and both his wife and his daughter had cancer, and he did put them both on hormone replacement. So he talks a lot about the ins and outs of it. So if you're concerned, if you are a cancer survivor, I would highly recommend reading his book. Laura Brydon, ND, she's just lovely. She's soft-spoken. I think she does her homework. I think she's probably the most conservative of everyone I've listed up here. But I think she adds a lot of value. And she wrote the Hormone Repair Manual. She has another book, the Period Repair Manual, I think. But for our age here, it would be Hormone Repair Manual. Dr. Felice Gers, she's actually in Irvine here, California. She wrote a really small book, easy to read, kind of a reference book, I guess you would say, on menopause, 50 things you need to know, easy peasy, Amazon. Podcasts. So if any of you are in podcasts, I like Dr. Mark Hyman, just for general information. He's a functional medicine doctor. He has the ability of taking kind of complicated ideas and bringing them down to layman's terms in a very, very nice way. I don't think hormones is his forte, and the people he has on there, I've listened to a couple and it's like, no, but everything else I'm in agreement with. Karen Martell is delightful, and her podcast, The Hormone Solution. She might be actually a source for you to give you a community and also be an advocate for you. She's really big out there in the hormone world, and listening to people she interviews and even to herself, very valuable. I found Danny Bennington, the next one here, menopause and cancer, probably about 3 months ago. And because I'm not a breast cancer survivor, I really don't know what a woman goes through. And I really don't know if you've lost someone close to you and have watched someone die of breast cancer or ovarian cancer, um, how that affects you, and and also changes your perception on the world of HRT. So I really like listening to her, so I have a better understanding. And she does have a lot of practitioners and even just cancer survivors on her podcast, explaining and talking about aromatase inhibitors, tamoxifen, different prescription drugs that you can take to help mediate some of the nasty side effects from all of those. So recommend her. YouTube, Dr. Felice Gersh, hands down, and Dr. Louise Newman, hands down. Now, on Instagram, if you're on that, Dr. Men, OBGYN, love her, love her. She gives great, straightforward information. She is a 2 or 3-time cancer survivor. She does take HRT, and I think her first bout of cancer was in her 20s. And she's got to be in her mid-40s by now. And I just think that she has a lot to offer, so I highly recommend her. All right, I think, okay, so I am going to stop sharing here.